911, what's your emergency?
On today's episode, we're going to be covering all of the medical, legal, and ethical issues pertaining to the EMT Basic. Like all doctors, when they get their medical license, they take what most people know the Hippocratic Oath, which basically states do no harm. Well, in our case, we don't take any oath, but the tenets are basically the same. So basically, as an EMT, when you're dispatched to a scene and you arrive and you find your patient, you don't want to do any more harm. A harm has already been done from whatever it is. If it's a medical issue, a traumatic issue, it doesn't matter. The harm's already done, but you don't want to either further make the patient sicker or you don't want to injure the patient any further. So everything you need to do needs to be very safe. You don't want to do anything outside of your scope of practice. Okay, scope of practice is basically what you're allowed to do by your department's or your state's or governing body's rules. And that says, okay, EMT Basics can do these things. Anything beyond that is outside of their scope of practice. So, for example, an EMT can give oxygen to a patient, no problems. You can, in certain states, give certain medications, like for example, albuterol, which is designed to help you breathe. Most people see it as the little inhaler, like for asthma. So you may be allowed to do it just by protocol. Like you'll have in your state or your department will have a book or some kind of means of seeing what's allowed and not allowed in your scope of practice. So your department may say you may give this drug, this albuterol, to a patient and not need to get permission. And they might say, okay, but you can give epinephrine, which is a drug that is used to treat an allergic reaction. A lot of people know EpiPens. So EpiPens are basically automatic injectors that you don't really have to do anything. It's already pre-measured and pre-loaded. It's a one-time use deal. You basically take the safety cap off, charge it, and then you basically press it firmly against the thigh of your patient. And most patients that have a known allergy, like to a bee sting, for example, or ants, or another most common allergy, shellfish. Shellfish is a big one, so they'll have an EpiPen, and you may either be able to help the patient use their EpiPen, or you can just do it yourself, based on your assessment of the patient and whether or not your department allows it. So you treat the patient with respect, but you also want to do things that will benefit the patient and not make them worse. In EMS, there is basically what's considered the chain of survival, or the links of survival, or the chain to definitive care. There are various ways of explaining it. Basically what it means is step 1 leads to step 2, leads to step 3, leads to step 4. So for example, this process starts with generally a phone call to 911. So that's the first link. Then the 911 operator gets the information and then will dispatch the appropriate responding unit. So if it's a law enforcement issue or a fire department issue, EMS issue, they would send the appropriate people. So that's link number 2, is getting the information to the in our case, we're going to say the ambulance. So when the ambulance gets to the patient and then does their assessment, if they just transfer direct to the hospital, that completes the link. The link is to go from notification to definitive care. And definitive care is what's going to ultimately resolve their issue, whatever it is. So if they're at a restaurant and they accidentally ingest, let's say, a shrimp, which obviously causes an allergic reaction, you get the call, you pick up the patient, you treat them on scene, you move them to the hospital, definitive care. So link one through the end. So that's basically the idea of how the process works. Once you actually get on scene, this is where it becomes a little murky, because depending on the condition of the patient, you have to get consent. Once you get on scene, the first thing is to, find your patient, and then once you find your patient, you have basically your ABCs, so that you do for every single patient. It doesn't matter what their call is, their chief complaint. It doesn't matter. Every patient, ABCs, airway, breathing, circulation. Okay, so you get to your patient. Once you get to your patient, you might say something like, "Hi, my name is so-and-so. I'm an EMT. I'm here to help you. Can I help you?" When they say yes, boom, you got your consent. So it's basically permission to treat. It gets a little murky once you start getting into patients that are incapable of giving you permission. For example, someone that's having a mental health issue. When you're dealing with a patient with mental health issues, for example, someone that's having a schizophrenic crisis where they're not oriented, they're off in some other world, but they need emergency help, you would just go ahead and give them help, because you would assume that if they were competent, they would give you that permission. So you apply under that's that involuntary consent. You're basically saying yes for them, and the idea is any further delays is not going to make the patient any better. It's just going to make it worse. So when you want to deal with a patient that's in those kind of conditions, is make sure you adequately document everything that happened on that particular call. Behavioral emergencies are especially dangerous sometimes, uncertain sometimes, confusing definitely. If you have a patient that's off in La La Land and is thinking they're the king of Siam, and they're riding an elephant into Pompeii, that might make treatment of that patient kind of difficult. Ideally, you want to just keep them calm. At the EMT basic level, there's not really much you can do for a patient in those kind of conditions. It's just get them from where they're at to the hospital. Once you get to your patient, and if you find they're unresponsive, they're unconscious, or whatever, you will treat them under what's called implied consent. And implied consent basically means that were that patient able to give you permission, they would. So a lot of problems arise from not getting the appropriate consents. So the first thing you should do once you've done your ABCs, your scene safety, your PPE, all those kind of things, is get consent, and then document it in your run report once you're done with the call. Another murky part is minors. Okay, anyone under the age of 18. If they're conscious and alert, technically they can't give consent because they're a minor. So you can try, if their parent is there, like for example, let's say something happened at a park, say a little girl fell off the swing set and broke her arm, and the parent is there, then you would just go ahead and get permission and consent from the parent to treat that child. If the parent's not around, then a guardian of some kind, like if it happens at school, for example, so a child is sick at a school, so the people at the school would then give you, temporary consent, so you can start treating that patient before you can move on to, getting more consent from a parent, for example. But ideally, you don't want to delay, especially with children, because children, they do well until they don't. They what's called decompensate. So their bodies are young and healthy, and then they can keep up with an illness, and they keep it up, and then their body just can't go anymore, and it shuts down, and it happens like that. So you got to watch for that decompensation, not decomposition. That's a totally different thing. Decompensation. So the body compensates for whatever the illness is until it doesn't. So delaying with a child can be more risky. So basically, you want to get them treated as soon as you can. You may have to restrain a combative patient. Combative patients range from, just argumentative and belligerent and up to full-scale violence. If you're dealing with a patient that is extremely violent, for whatever reason, they're high on some kind of drug like PCP, which makes their bodies super strong, and you're not going to be able to contain that by yourself. So you want to have as much backup as you can. Other EMTs, for sure. Paramedics, definitely, because they can give medications that can make the patient comply. You want to have all the backup that you can get. Other EMTs are great. Law enforcement, great. Paramedics, on the other hand, they can give certain drugs, we call them chemical restraints, that can be used. You don't want to injure the patient when if you're securing them to their gurney and they're fighting with you. You don't want to injure them, so you want to restrain them in a way that's not going to cause further injury, but at the same time, you don't want to let them be able to hurt you or somebody else. And you also want to make the hospital aware of that when you're en route, once you make your radio call. You'll call into the hospital with your patient condition report, basically an outline of age, chief complaints, so what's the problem with the patient, your ETA to the hospital, anything you've done for the patient, vital signs, basic stuff. That way it alerts the hospital ahead of time that you're coming and roughly what time to expect you. So if you say I'm 7 minutes out, so they know in about 7 to 10 minutes or so, you're going to be pulling up to their back door. So they're ready for you. All patients, if they meet certain criteria, can refuse treatment. It happens all the time. You'll get a call to a patient with some kind of issue, and then when you pull up, you might do some vital signs, talk to them a little bit, and they'll say, no, you know what, I'm okay, I'll just go, I'll have my wife take me, or something along those lines. That's fine, but make sure when you document the refusal, you'll have a form, you'll have them put their name on, sign, and basically what that is it's a liability release. So you don't want to leave a patient without documenting those kind of things, because that becomes abandonment, which is a totally different and a serious legal charge if you abandon your patient. So document it, fill out the form. If you have law enforcement on scene, have them sign it. There's usually a line on the form that says law enforcement personnel, and have the name, agency, whatever, they just sign it. A lot of departments now are all digital, so it's like on an iPad. They can do all their patient care reports right there on the iPad. Click a button, sign it, you're good. Some departments aren't that advanced, and everything's still on paper. When I was doing it, iPads weren't a thing, so you had to write everything out. So if they're alert, they know where they are. They're of sound mind. They can refuse. If they're unconscious and then they become conscious, for example, let's say they had a drug overdose, and you gave them a drug called Narcan, which reverses opioids like heroin, fentanyl, which is a big thing now, and they wake up and they want to refuse treatment. Be very, very careful, because those drugs have a short half-life, and then they can relapse. So ideally, you want to bring them to a hospital to get them treated appropriately. Obviously, you can only do so much in the field, but be very careful if a patient refuses treatment. Even before you leave, they fill out the paperwork and everything. Before you walk out the door, you turn around and say, "Are you sure you don't want to go to the hospital, sir, or ma'am, or whatever?" And if they still say no, okay, have a wonderful night. If you need us, call 911 and we'll come back. So that's basically what you want to do. Is you want to protect your butt. CYA, right? Cover your own posterior. So take care of your patients the best you can, and just make sure that you document. If you don't document, it didn't happen. I will expand on documentation in a later video. Today is just I want to cover like the medical legal things pertaining to the EMT. Confidentiality, on the other hand, when I first started doing EMS, HIPAA wasn't a thing. So when I retook the the class for the second time, they introduced HIPAA, and I was a little confused about what it was. And basically, what it is, it's information security. If you're, in an elevator, and you're, in an elevator with a bunch of other people, you don't want to be talking about your last patient to your partner or to another provider or another ambulance crew or whatever, because you don't know who's riding in that elevator. It could be that person's family. So if you get some kind of funny call and you want to laugh about it, that's fine. Just don't do it in public. Do it in private. Be respectful, and don't share patient information. That's why whenever you see these scenarios in training, they'll say a 58-year-old female or a 12-year-old male or whatever. So there's no distinguishing characteristics other than gender and age. And of course, gender and age are descriptors, but they're very broad descriptors. But just out of respect for your patient, don't talk about them in the hallway of the hospital. Don't talk about them in the restaurant, in the cafeteria. Just keep that stuff to yourself. A lot of times, you'll when you first start doing EMT stuff, people will ask you questions like, "Oh man, what was your scariest call?" Or "What was the grossest thing you ever saw?" Or "What was the funniest thing you ever saw?" Those kind of questions, just be careful. You can tell them. Let's say my funniest call was about 2 years ago. Blah 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 happened, but don't go into any detail. Just general broad strokes. A lot of patients know that their illness, say it's cancer or some other issue, is a terminal illness, and they don't want any life-saving measures when that time happens, when the time comes. They just want to let them go, okay? And you'll have a form called a DNR, which is Do Not Resuscitate Order. So if you pull up to a call and your patient is in cardiac arrest, don't stop and ask, is this patient a DNR? Just start doing your work. Unless the family says, stop, we have a DNR. Keep going until you physically see the DNR. Don't take their word for it. And it has to be signed by the patient or someone that legally representing the patient with a power of attorney and a doctor to make it valid. So you need to see that DNR. Some states might be different. Things may have changed since I was in the EMS world. So follow your own local protocols and your own laws. But generally, if you're going to get a call and a patient needs help, you help them. Just because they don't have if they have a DNR, that doesn't mean you don't treat them. I mean, they could have an illness that's not related to, anything else. It's just, let's say they have a cold. Does that mean you're not going to, if they're a DNR, you're not going to help them with their cold? I mean, you still have a duty to provide them with comfort. So if they're having a little difficulty breathing, give them oxygen. If they're scared, try and talk to them. Try and, make them not scared. If they're cold, give them a blanket. There's no reason why you shouldn't do everything in your power to keep that patient comfortable. In the back of your ambulance, you may be sweating bullets, but elderly people, especially elderly women, lose the ability to regulate their body temperature very well. So it could be 80 degrees outside and your patient's cold. Turn up the heat in the ambulance. I mean, you might suffer for a little bit, but by doing so, you make your patient more comfortable. help them out. It's not rocket science. Um, a lot of patients will have other advanced directives, like they'll allow this but not that. Like they'll allow oxygen but not intubation, which is sticking a tube down their throat into their trachea, which is this structure right here, or the windpipe, goes into the lungs to help them breathe. So you can give them oxygen, but don't intubate, right? As an EMT Basic, you're not going to be intubating anyway. That's a paramedic level skill. But some states allow EMTs to use an LMA, which is a laryngeal mask airway, which is similar, but it doesn't actually go into the lungs, and it's a blind insertion tool. You just kind of shove it in, following the natural anatomy of the pharynx, and it basically covers up the trachea. So when you squeeze that bag, it's called a BVM, a bag valve mask. When you're squeezing that, it's forcing air into their lungs, and you really use those if the patient can't protect their own airway, if they're unconscious or something else is happening with a patient, they can't protect their airway, you would use something like that, or a combi tube. Combi tubes basically another blind insertion technique, which are designed to help secure an airway. So do what's in the best interest of your patient, and they might be scared. So try to be that calm, that voice of reason, especially family. Family will be generally more supportive and understanding with a patient that has a known illness and is progressing to the end of that illness. But when it's sudden, be careful. Even if it's a sudden cardiac arrest and if they have a DNR, you gotta honor it. It's not rocket science. Take care of your patient. I'm not really going to go into death and dying so much. I mean, certain schools will go through the 5 stages of death and dying, the grief, acceptance, bargaining, anger, all those. We're not going to go through that kind of stuff. But basically, I just want to give you a quick overview on, if your patient is going to benefit from any care, or if they're already pretty much dead. So obviously you don't just leave a patient, you confirm it. And some states and departments allow EMTs to call medical direction, which is a physician at the hospital. They're designated as medical direction to give them an update on a patient. They might call up and say, this patient was found cold, pulseless, and apneic, which means not breathing, no pulse, on the floor. Basically, they're basically dead. Okay, but they're not in rigor mortis yet, so it might be a recent death. So if you roll that patient over and start doing CPR, it's not going to do anything. They're gone, but you can't just leave them there without checking it. And so you give them the information. They may say, okay, go ahead. He'll assign the time of death. Let's say it's at 15:30, which is 3:30 in the afternoon. And then you fill out your run report saying patient found pulseless and apneic, cold, on the floor of of the house, called medical direction, provide information. Medical direction said pronounced time of death. So there you go. So that's kind of it's not definitive until you check. Now, especially with cold death, like for example hypothermia, there's a saying in EMS that the patient is not dead until they're warm and dead, and that's because when the body gets hypothermic or cold, all the blood from the extremities, like the hands and the fingers and the toes, all get pulled into the center to protect, your vital organs, your heart, your lungs, your digestive system, your brain, your vital organs. So it's called shunting. So all the blood is just pulled, and that way when you touch them, their hands, arms may be ice cold. And when you feel this for the first time, you will know what I'm talking about. They're not dead until they're warm and dead, so you still transport them. Other signs of death, obviously, an obvious death like a decapitation, for example, they're obviously dead. You're not going to do anything. It's usually at that point in time, it's a medical examiner's case, and they're going to take it over. You may transport the body, happens all the time, to the morgue or to not generally to a funeral home. Usually the funeral homes will come to the site of death, and they'll pick up the patient and then take it to the funeral home. That happens all the time. Especially with someone who's on home hospice. So if they're on home hospice, they die at home, all it basically is you go there, you confirm the death, and then you call the funeral home, or the family will call the funeral home, and then they'll take over from there. But if someone's in rigor mortis, where their body becomes stiff, or if they're found, like if they're laying on their back, right? Let's say they died in bed. And they may be dead for a day or two. What will happen is all the blood from the body will drain into the lower parts of the body because of gravity. And what will happen, that's called lividity. And you'll see purplish bluing of the skin, kind of where the body is making contact with the surface. I mean, that's obvious sign of death. Obvious decomposition. Like if someone's been down for several days, the body will bloat, different things will happen. You'll see insect larvae, flies, very pronounced smell. Word of advice, if you've never smelled death before, just be very, very careful because it's overpowering. A lot of people spray like an air freshener on the inside of like a mask, like a HEPA mask, and then they put that over, and that filters out some of that. I mean, it doesn't filter it all out. I've had calls where I've had to go in full firefighting safety gear with the mask and the air tank and all that because of advanced states of decomposition. So those are obvious signs of death. So if you were to come across that, generally you wouldn't be the first one on scene. Usually law enforcement would be the first one on scene. And you probably wouldn't even be called because it's obvious. So things like that. Crime scenes, be careful. Because when you enter a crime scene, everything that you do from that point on can become and can disturb evidence. So you want to be very careful where you're stepping, very careful where you're touching. Let's say a patient was stabbed and they're on the ground somewhere and they're bleeding out and you're called in to treat the patient. You don't want to just go and cut their clothes off because the knife wound in the shirt, for example, is evidence. So you want to use your scissors carefully and cut away from that and try to avoid cutting through blood stains and things like that because those are all evidence. So you'll respond to crime scenes. So like I said, just be very careful with what you're doing. Document everything as best you can. Some crime scenes are, there's nothing going on. It's a fight, right? And there's two people that were involved in the fight. Still a crime scene, still evidence, but not nearly as bad as, say, someone that's near death and you coming in to try and save them before they do die. So just be careful with crime scenes. Be careful with disturbing evidence, creating evidence. These kind of things will be learned by doing. Some departments will have special training for dealing with crime scenes. Some don't. It all depends on what your department wants to do. Okay, so duty to act is basically you have a responsibility to provide care for a patient. Okay, so if you're on duty in your ambulance and you get a call, you're obligated to go to that call and treat that patient. That's your duty to act. Now, if you're a licensed certified EMT and you come across an issue, for example, someone drops in front of you with grabbing their chest, you do not have a duty to act because you're not on duty. But you still should. I mean, if you got the training and you're right there, you should be helping out. Just be, cognizant of any legal ramifications that could potentially arise. Also, like if you were to pull up onto a traffic accident, still no duty to act, because you're not on duty. But if you are on duty and you come across an accident, for example, you're driving down the road back from getting lunch or back from a call or whatever, and you happen to pull up on a traffic accident, you should stop and see if anyone needs help. If law enforcement's not on scene yet, you should be calling your dispatch and letting them know that there's a traffic accident, where it is, how many vehicles involved, if you can tell, if there are any injuries, those kind of things. Any resources that might be needed. Let's say there's fluids leaking. Let's say it's got a punctured radiator and it's leaking coolant. So you want to notify dispatch so that they can get the appropriate people coming to deal with whatever the situation is. Even if it's just a minor fender bender, nobody's hurt, nobody needs anything, you still should check. It's important, if you're going to be a first responder, to be a responder. Negligence, on the other hand, if you do something outside of your scope of practice, so like we talked about before, if you're not authorized to start an IV and you start an IV, well, guess what? That's negligent. Whether it results in harm to the patient or not is irrelevant. It's still negligent because you're not trained to do that procedure. Even if you are trained to do that procedure, if you're not certified to do that procedure, you don't do that procedure. It's just that plain and simple. Because you don't want to put yourself at any legal risk of going to jail for doing something that you thought was helpful, but wound up not being helpful or whatever. In this society where everyone is super heightened about filing lawsuits and stuff, CYA, again, protect yourself. Abandonment. Obviously, with a term like abandonment, that means just leaving your patient. There are certain circumstances where you don't have a choice. Let's say you're in a situation and you're in a vehicle accident and you're trying to treat your patient who's still in the vehicle. Let's say they're trapped and the fire department is using their rescue tools to remove that patient. And if something were to happen where that vehicle were to catch fire, you got to get out of that vehicle and get away. If your patient obviously can't and they die or are injured as a result of that, that's not abandonment, because you are not doing it in a manner that's not proper. You can't save anybody if you become a casualty. So that's why when you're seeing those kind of accidents where there's someone trapped in a vehicle and they're using rescue tools like the Jaws of Life, for example, you will always see at least one, maybe two firefighters holding hoses ready to start, fighting the fire if one were to develop. So that's just an example that's not abandonment. But if you walk into, let's say a bar, and two people were fighting in a bar, and they're cussing you out, hey, F you, I don't want you, and you turn around and you leave, and you don't get some kind of documentation, abandonment. So don't abandon your patients. These are kind of more abstract ideas. Abstract because they're not generally thought about when you're trying to treat a patient. But as an EMT, if you're treating a patient, you can be considered guilty of assault, battery, kidnapping. So basically, you want to protect yourself. Again, let's say you were to threaten your patient. Like, if you don't do something, I'm going to do this. That's technically considered assault. Okay? Now, if the patient is compliant and everything, and you pick them up and you slam them down on the gurney or something, that's battery. That's where it could potentially cause injury to that patient. That's battery. It's a murky gray area, especially when you're dealing with combative patients, because you have to do what you do to protect your patient, but you also have to protect yourself. So like I said before, document everything that happens from the time you're dispatched to the time that your call ends. Documents. Kidnapping, transporting someone without their approval or consent, if they're able to give consent, and you say, I'm taking you no matter what. Get on my gurney, you're gone. That's kidnapping. So don't do that. This next one is kind of complex and difficult to understand. It's called the Good Samaritan Law, and if you're familiar with the story of the traveler that found the injured man on the road and stopped to help him, and that's like it's an old biblical story, and that's where that term comes from. And the basic principle is that you're not liable for any kind of harm or anything that comes to that patient if you acted in good faith, you weren't compensated. So like if you were to see somebody on the side of the road that had a cut, and you put a bandage on their cut, you're not compensated for that. That's not legally troublesome. If you're on a call and you act within the scope of your training, your scope of practice, and there's harm results, you're not liable because you have done everything according to what your training specifies that you do, and you didn't exceed your training, and you didn't do anything negligently. So, for example, if you were to, start an IV, let's say you were allowed to start an IV in your jurisdiction, and you did so without, applying antiseptic, like an alcohol wipe or something. Technically, that could be considered negligent because that's part of your training is to, sterilize that area before you put a needle in, because you don't want the patient to get infected, right? Reports and records, as I stated before, if it's not documented, it didn't happen. These reports are legal documents that will be used in court if something were to happen where you would be called to testify. You are allowed the opportunity to review your records from that to refresh, because in a course of any given week, month, year, you're going to see hundreds, thousands of patients. So let's say something happened 2 years ago, you're not going to, remember that unless it was really a really big case where everything just stood out. But if it's something, you don't remember, you're allowed to review your records. So you want to document in a way that the layman reading your report, like on a jury, would understand what you were trying to communicate. You can use medical jargon and medical terminology and medical abbreviations and things of that nature, but you want to do the best you can to keep it so that it is understandable to the layperson off the street. Because most people are lay people off the street and they don't have that kind of medical training that you have. So if you write a report in nothing but medical jargon, no one's going to understand it but you and other people in your profession. So document clearly, concisely everything that happens. If you gave a medication, what medication you gave, when you gave it, how you gave it, and what you did to assess that medication you gave. So all those kind of things. Let's example. Someone was having an allergic reaction. You respond to the scene. Patient was on the floor with hives on their face, wasn't able to breathe. They couldn't talk. You gave them an EpiPen. You say, I gave EpiPen, right leg, medial thigh, at, let's say, at 1700. Patient began experiencing less difficulty breathing as a result of the application of the medication. Gave patient oxygen, transported to the hospital. So basically what you did is you said what you gave, how you gave it, and then what the result of that was. There's a phrase you need to remember. Some departments, some people say it differently. This is how I say it. 1, every patient deserves an assessment. 2, not every assessment needs an intervention. 3, every intervention requires an assessment. So basically, I'll break it down. So every patient you respond to, you're going to do your ABCs, your airway, brain circulation, vital signs, history, all those kind of things. Assess your patient, treat your patient. If your patient doesn't really need anything, they just need a ride to the hospital, then that's what you do. But if they need something, let's say their oxygen levels are showing low on the pulse oximeter, which is a device that goes on the fingers that reads the blood oxygen concentration through the thumbnail or through the fingernail, and let's say it's 90. That's low. Normal is considered 95 to 100. So you give them some oxygen, then you want to document that you gave them oxygen, how much oxygen, by which method, and then what that oxygen did for the patient. So let's say patient was 90% SpO2, place patient on 2 liters of oxygen via nasal cannula. O2 saturation is up to 96. And there you go. You documented all those items. So you documented your assessment, your intervention, and your assessment of that intervention. So there you go. 3 items. Just like that. Every patient deserves an assessment. Not every assessment requires an intervention. Every intervention requires an assessment. And continuing assessments. As you transport, let's say you've got a 5-minute transport time, and you don't really have a lot of time to do anything. But if you've got a 30-40 minute transport time, you should be checking their vital signs every 15 minutes. If for a medical stable patient, for a non-stable every 5 minutes, and for every trauma patient every 5 minutes. Just that way you keep documenting. And if you'll notice there's any trends, so you'll see if their blood pressure is trending lower and lower and lower, or is it staying the same, is it trending higher? These kind of indications will give you a clue of whether or not your patient is needing further assessment, further intervention. So that's basically what I'm getting at. People in the medical field, EMS, law enforcement, psychologists, we're what's considered mandatory reporters. So if something were to happen that would lead you to suspect some kind of issue, like for example neglect. So your patient is elderly, let's say she's very filthy, malnourished, dehydrated. These kind of things are indicators of neglect. It doesn't necessarily guarantee that there's neglect, but it's an indicator of neglect. So, if you respond to your patient and they looks like they haven't eaten, they're filthy, they're dehydrated, those kind of things, you need to report that. If to no one else, to the ER, and let them take it from there, because they can get social services involved to further investigate. You want to document anything you find like that. Like if you were to respond to a house of a hoarder, for example, and you see the filth, and let's see there's animal feces all over the place, or a dead animal, for example, those kind of things you need to report. And report especially those kind of conditions to the hospital, law enforcement. Other mandatory reporting issues are abuse. It doesn't have to be sexual. It could be physical abuse, sexual abuse, child abuse, you name it. There's a huge spectrum of possibilities. Probably one of the biggest and most obvious ones is a sexual assault or a physical assault. So if you see a patient that has multiple broken bones or bruising in various stages of healing, like you'll know an old bruise from a newer bruise. These kind of things are indicators that there's some kind of an abuse going on. Also, the patient's mental status, if they're scared, withdrawn, angry, these kind of things are all indicators. So you want to do your due diligence when you're dealing with these patients, especially in victims of sexual assault and domestic assault. You want to be as calm, professional, reassuring. Your patient is a young female. It might not be a bad idea if there's 2 males on your ambulance. You might not be a bad idea to get a female if they're more comfortable with that. either female EMT, female law enforcement, something along those lines. So just I don't want to tell you exactly what to do because it's going to vary state to state. Just as a general guideline of things to look out for in your day-to-day work as an EMT. You are going to see some truly horrendous things. There's no sugarcoating that. Advanced decomposition, decapitations, suicides, gunshots, stabbings, vehicles being people being run over by vehicles, and then the different levels of abuse. And so you need to be empathetic, you need to be professional, non-judgmental, and that's very difficult. And you want to be reassuring and calm. Keep your patient calm. Keep yourself calm. There is a program called CISD, which every department has a version of, which is Critical Incident Stress Debriefing. Every person should avail themselves of that when they have something that causes them distress. It could be just simple as talking to somebody else about whatever it is, a counselor, a clergy member, a friend, and then it could escalate up the ladder. So those kind of things, and there's a formal process for the way CISD works. So just, you got to take care of yourself. You got to eat well, plenty of sleep, those kind of things will help you reduce some of that stress. So basically, just take care of your patients. In all honesty, that's really all you need to do. So, if there's any further questions or anything you want me to go into further detail on about some of these things, let me know in the comments, and I will try to give you some information on those. On that note, thanks for watching. The next episode will be about the ABCs of the EMT. And what that means is we're going to talk about all the abbreviations and acronyms. We're not going to talk about all of them because there's thousands. We're going to talk about some of the most common ones that you'll see on a day-to-day basis, just so I'll give you a brief overview of what they are, so you're not totally confused when you start hearing these terms for the first time. And the second part is going to be about basic anatomy. We're not going to talk about in-depth stuff like the cardiovascular system, the respiratory system yet. We will talk about those when we get to those parts of these videos. But we're going to talk about how the body is designed, separated, and the terminology that goes along with that. So these first two videos, the one that we're doing today with the med legal, and tomorrow, well, not tomorrow, but the next episode will be the ABCs of the EMT, are basically the driest parts. Once we get through these two, then we can start getting to the interesting stuff. But I really want to get a good foundation under your belts before we move on. So on that note, thanks for watching.
911, what's your emergency?